good afternoon, everybody. We'll try to move away from kidneys and tiny babies, and certainly from marijuana. We'll talk a very important topic, thalassemia. I'll try to focus my talk on beta-thalassemia major. That's good. So we'll talk today about pathophysiology of thalassemia, natural history of disease, complications that patients suffer from, and milestones in diagnosis and management. And lastly, we'll talk about some treatments, especially hematopoietic cell transplantation. And we'll introduce to novel future therapies. So thalassemia is an old disease, actually, and it was first discovered in the 19th century when it was most likely called porotic osteoporosis or hyperostosis. And this was discovered on the skulls of some patients who died from anemia. So this disease was like thalassemia, actually. And that was in Sicily and Sardinia, one of the biggest two islands in the Mediterranean Sea. In 1889, anemia infantum pseudoleukemia is another term that was given to patients who used to die, thinking it's pseudoleukemia. But that could very likely be also thalassemia. Could be others, of course, like leishmania or tuberculosis. Thomas Cooley in 1925, and this is where the other name of beta-thalassemia major came from, Cooley's anemia, was the first one to describe a series of cases with splenomegaly and peculiar bone changes. And he was a pediatrician from Michigan. And then Dr. Whipple and Bradford, pathologists from Johns Hopkins, described a Mediterranean disease called thalassemia. So we can see here the thalassemia belt. It spans most of the Mediterranean area, Southeast Asia, Europe, and South Africa, and some North African regions. And the reason why thalassemia is endemic to these countries, like we all know, is this is the area where malaria is endemic, and thalassemia carriers can be protective for disease of malaria. The other reason is consanguineous marriages in most of these countries, and that contributes to more of thalassemia, which is a genetic disease. So to understand thalassemia, we have to understand pathophysiology. So what happens is it's a quantitative defect of beta chains. We know that hemoglobin is beta chains, alpha chains, and in the fetal life and early newborn period, there are gamma chains. So thalassemia basically is reduced or absent beta globins. That will lead to an excess alpha globin chains. And we know that alpha globin chains are unstable in the human body. So that will make them precipitate, mainly in the erythroid precursors in the early young red blood cells. This will lead to premature death of those cells in the bone marrow itself before they go out. And that is called ineffective erythropoiesis. So there is production of red blood cells and maturation, but it's really ineffective because there will be premature death. Those cells who survive destruction and pass to the peripheral circulation, they will be destroyed extravascularly in the reticuloendothelial system, mainly the liver and the spleen. And that's what made it a hemolytic disease or a hemolytic anemia. This is because of the membrane damage, also due to excess alpha globin chains. Both of those mechanisms can lead to anemia. And anemia itself will increase iron absorption. So this happens trying to compensate for anemia. So there will be increased iron absorption, which will contribute to the iron overload. But we will see later that iron overload in these patients are mainly from transfusions. There will be erythropoietin increased, which trying to make more red blood cells. That will lead to the bone marrow expansion. And this is which will lead to prominent bones and specular thalassemic faces that we will see in the next slide. So prominent bones in the face, you can see here, this is all due to bone marrow expansion, trying to compensate for anemia. Hairy ends or sun array appearance in the skulls. And this is actually an active area of research, trying to decide when does anemia and thalassemia originally discovered by checking the skulls in certain countries like Italy. you can see a huge spleen here. And this is because of hemolysis extravascularly. It's the main reticuloendothelial system. Luckily, these are old pictures, and we don't see this as often these days due to better supportive therapy for those patients. So to talk about thalassemia, we now have to diagnose thalassemia. And the two most common causes of microcytic anemia we encounter is iron deficiency anemia, as well as thalassemia, thalassemia minor, which is the thalassemia carriers. And to make the distinction, mainly both are anemias, but the MCV, how small the red cells, it's much smaller in thalassemia carriers. And as we said, there is a compensation to produce more RBCs, so those will be high, while it's low in RBCs because there is no iron. One very useful index is Menzer index, basically the numerator over the denominator, MCV over RBC count. And this, if you imagine here, this will be lower for thalassemia. So if it's less than 12, it's usually thalassemia carrier. If it's more than 14, it's iron deficiency. If it's in the middle, it's a gray zone. And you have to depend on other tests. Hemoglobin electrophoresis is the next step. And normally, our hemoglobin consists mainly of hemoglobin A, 97%. Hemoglobin A2 is 1 to 3%, which is alpha 2 delta 2. This is alpha 2 beta 2. And hemoglobin F alpha 2 gamma 2 is less than 1%. It's usually high when babies are born, but then it will continue to decrease. In thalassemia carriers, hemoglobin A2 is more than 3.5%. So this is the number we will focus on. And in major, of course, it's all F because there is no beta chains to make hemoglobin A. And one important thing is if the patient has both iron deficiency and thalassemia, this number may be normal in thalassemia carriers. So because iron is important to make hemoglobin A2, so if you're iron deficient, the 3.5% will go lower. So he may have a normal hemoglobin electrophoresis. So then genetic testing becomes important. This is a peripheral blood smear from a patient with thalassemia. And you can see the microcytic cells, you can see hypochromia, some target cells, and occasionally you see basophilic stippling. So how does babies born with thalassemia? So you have to have a carrier father and a carrier mother to be born with thalassemia, and the chance is only 25%. There's 25% you're healthy if your parents are carriers, and 50% chance to be carriers, and this continues. Okay, so the problem with thalassemia is really what happens after. It's the complications of thalassemia. You can see iron overload is the main complication that can happen because those babies will die from anemia if they don't receive transfusions. And when you receive transfusions, every blood unit has certain amount of iron. And iron loves certain organs like liver and spleen, heart, glands in general. So it tends to precipitate here and causing problems with time and organ failures. Infections. Patients with thalassemia does not have a normal immune system, so they tend to have more infections with time. Heart failure from iron overload, arrhythmias usually from iron overload that can precipitate with time. Liver disease usually from iron, but also in the past, blood was not so safe to transfuse. So hepatitis and HIV were common diseases that can affect the liver. In addition to pulmonary hypertension and thrombosis, especially if those patients are splenectomized. So natural history. So to assess the treatment for any disease, you have to understand the natural history of the disease. And patients with thalassemia, if they don't get blood transfusions or if they don't get regularly, they will die before reaching 5 years of age. And that was the case about 60 years ago. And then if they received regular transfusions but no iron chelation, then they will die and suffer from manifestations of iron overload at the end of the first decade to the second decade. While if they receive optimal supportive therapy with blood transfusion and iron chelation, then they may enter normal puberty and adult life although quality of life would not be the best. This is a very nice slide that can summarize nature history of thalassemia. So in the 50s, 60s of previous century, most patients, you can see the purple color, used to die from anemia. While in the 70s, 80s, and 90s, it's usually the red color, which is complications of iron loss. So transfusions started here, but then iron chelation was not really optimal. And after 2000s, nobody dies from anemia. It's usually iron complications plus other causes that can complicate the disease. So we know that anemia was a dreadful disease. Patients used to die, but now it's really a chronic condition. It's like diabetes and hypertension. And thanks to the milestones that happened with time. So the first milestone is really transfusion therapy, started in the 60s and 70s of the last century. And transfusions really improve quality of life for patients. As we said, it will suppress ineffective erythropoiesis, so it will suppress all complications that comes with it. Now, transfusions are safer. There are screening for infections, hepatitis, and HIV. There's leukoreduction, which is filtration of white blood cells when you transfuse. That will decrease febrile reactions, decrease CMV transmission and infections, in addition to alloimmunization, which is production of autoantibodies with frequent transfusions. And more recently, RBC genotyping is done for those patients so they can avoid alloimmunizations. You can see in this the effect of blood transfusion on survival. So if there is no blood transfusion, usually no patient survives, while with transfusion, they really have long, this is in the very early years. And the advantage of high transfusion therapy is really to suppress ineffective erythropoiesis. You prevent splenomegaly from happening like we saw in the first picture. You decrease iron absorption from the intestine and better quality of life. The other milestone is how to measure iron overload. So the easy way is number of blood transfusions. So the more the blood transfusions you receive, the more the iron overload you will get. But ferritin is really a nice objective measure, but we know that it has very limitations because it's non-specific and it can be up for with many other reasons. So there are more newer techniques now, like T2 star MRI, which is just an MRI that can measure iron overload, and it may spare us from doing liver biopsies. And lapile plasma iron and non-transferrin bound iron is another measurements. This is the bronzing of the skin with dark skin with iron overload that we see in most of our patients. So the third milestone is iron chelation. Like we saw in the 70s, 80s, and 90s, people used to die from iron overload. So there are 3 approved iron chelators these days. Deferoxamine, that could be subcutaneous or IV, and 2 oral formulations, deferriprone and deferasirox or XJAB. And when do you start these agents? So you will read that you started after 15 blood units, 15 units transfused, or 15 to 20, or when ferritin is more than 1,000. But for thalassemia, if you know you're dealing with a patient with thalassemia, you know that these patients will continue to require blood long term. So you can start them earlier, actually. Because one important concept is iron toxicity. It depends not just on the tissue concentration, but also on the duration of exposure and rate of accumulation. So a patient who receives blood for 5 years, he is not like a patient who received blood for 10 years or 15. Even with good chelation, there will be more accumulation of iron with time. And this nicely summarizes the overall survival in the old days, while with transfusion, chelation, more recently becomes more than 80% to 90%. Okay, so we talked about how optimal we have to do transfusions and chelation, but really it's a tiring process, and it's a huge burden on not just the patients, but their parents and the healthcare system as well, and physicians. So people will require long-term visits, follow-ups, frequent lab tests, and their quality of life would not be really optimal. And caring for thalassemia is also not easy. So it requires long-term follow-up starting from birth, growth, development, school, work, sexual life, and almost all other organs, pregnancy. So require a multidisciplinary team. It's like imagining, like Dr. Scott is making fasulia himself, I guess. So on top of this, blood transfusion and chelation is not curative. So despite all this and decreased quality of life, this does not cure thalassemia. So you will have thalassemia all your life. Even if you survive till the 40s or 50s, you will still have thalassemia. And the cost, if you think about the cost, it's really costly. It will cost hundreds of thousands if you survive till 40s with all these follow-ups and blood transfusions. One study that looked at quality of life, the average scores on those patients in many of the domains were lower, and they dropped steeply after the second decade. Okay, so thanks for hematopoietic cell transplantation. So this is the only curative therapy that is proven efficacious for thalassemia these days. And the first hematopoietic cell transplant was in 1982. It was done by Dr. Thomas. And transplant doubles really the expected lifespan. So patients, when they survive transplant, can live normal lives. Timing matters, like we said. So the earlier you do the transplant, before 7 years of age, in other studies before 10 years of age, the better the patient, because iron accumulates with time. So the earlier you do hematopoietic transplantation, the better. Quality matters, and the best results that were obtained all over the world for transplantation is when there is a full HLA-matched donor. Usually it's a sibling, a brother or a sister. And in our area, it could be a cousin or a father or a mother, given consanguinity as well. So there is 50% chance to find a full match donor. And we can see that survival really approaches 95% with transplantation from matched donors. And thalassemia-free survival is 90%. So even if thalassemia came back, they can be salvaged easily. And just to remind everybody about the concepts of bone marrow transplantation, so the first step is to identify a donor. So there have to be a sibling or a relative that is fully HLA matched. And then you do conditioning regimens. This is chemotherapy plus minus radiation. And this is to ablate the bone marrow so the new cells can come and dominate. And then you infuse the stem cells that you collected previously from the donor. Then there will be a phase of neutropenia and then success of transplant when the new cells really settle in the bone marrow, and then follow up for the patient. And some advancements in the field of bone marrow transplantation is a score, it's called Bizarro score from Italy. And if you look, it depends on how big is your liver, the fibrosis, and chelation. And class 1 is mild, class 3 is severe. So you have to detect patients or to get patients to transplant usually in the first 1 or 2 phases. In the third phase, it becomes severe, so survival can be less. But now, reduced toxicity regimens are being developed, especially for this class with a severe disease, to get survival outcomes of more than 80%. Supportive care, many complications can happen with transplant, and there are newer medications that can treat those. Haploidentical transplantation, so this is when you don't have a full HLA matched donor. Haplo means a half HLA matched donor. And this is being done, but it's experimental at this point. So we talked about supportive therapy, we talked about stem cell transplantation. There are future therapies that are being developed, but none reached the stage of use in humans yet. One is gene therapy, other is inhibition of gamma globins. So the last few slides will focus about gene therapy. And what gene therapy basically is, so you don't need a donor, so you get cells from the same patient, so that will remove the limitation of finding a donor. You do apheresis, you mobilize the cells using some growth factors, and then you have to have vectors, viral vectors, with the normal genes. And through a process of transduction and then reinfuse into the patient, you hope for the new normal cells to settle in the bone marrow. So still need chemotherapy to ablate the bone marrow, but you don't need the donor as well. And there are, a couple of months ago, there was a study in the New England Journal of Medicine, and that was the first study on gene therapy. Was published on phase 1-2 trial, 22 patients, some of them are young adults, some of them are kids. Median follow-up is almost 2 years, and you use busulfan chemotherapy to ablate the bone marrow. You can see here, so most of the patients, around 15 patients, stopped needing blood transfusions. And the dark blue color is the duration of follow-up from the last blood transfusion unit. Some patients with a severe genotype, which almost about 1/3 of the study population, still requiring blood, but the amount is less. And this could also be beneficial regarding quality of life. Last couple slides, Hemoglobin F Inducers. So what happens here, we said excess alpha chains is what's really the problem in thalassemia. So if you have a way to increase gamma chains, that will remove the factor of instability of alpha chains and decrease ineffective erythropoiesis. So there are hydroxyurea. It's more successful for sickle cell instead of thalassemia. And there are some ways to induce gene promoters or silence gene repressors to do this. This is leg ulcers that really improved with time. Last slide, sorry. If we talk about thalassemia treatment, we have to talk about prevention. And Dr. Qasim Sharshir, I think he's with us today. He's doing a great job regarding this. So basically, carrier screening program. So this is to screen for carriers before they get married, to avoid marriage of carriers. And this program has been done in Jordan, and we have good results and improvement with time. Those patients who still decides to marry despite being carriers, a prenatal diagnosis can be helpful, so abortion can be done in the first trimester. If some people are against abortion due to cultural or religious reasons, there is a new way of pre-implantation genetic diagnosis. So using IVF and assisted fertility, then you know if the embryo will be affected with thalassemia, and you don't really insert it in the uterus before. Thank you, and thanks for listening.